Good afternoon, everyone, and thank you, Chairperson Madam, for that introduction. Warm greetings from India and South Asia, and warm greetings also from the International Society of Endocrinology. It's great to be part of the BDER, and I appreciate the wide spectrum of topics that have been chosen for today's talk. Now, when we speak of diabetes, people criticize us. Earlier, they used to criticize us for being very glucocentric, and that is true. But then you must understand that diabetes is a very young subject. We are just 100 years old. It hasn't been long since we created insulin. And if you look at endocrinology, we are even younger. Modern endocrinology actually took off just about 50 years ago when radioimmunoassay was discovered. And last year, we celebrated the 100th birth anniversary of Rosalind Yalow, who is said to be the mother of modern endocrinology. Why is Dr. Rosalind Yalow called the mother of endocrinology? Because she created RIA, radioimmunoassay. And it's only after that that we could measure hormones in a proper manner. Before that, we had to rely on biological assays. So even, like UPT, urine pregnancy test, is so simple now. That's an endocrine test. But earlier, you would have to sacrifice one rat or one rabbit just to diagnose one human pregnancy. It used to be that difficult. So earlier, we were glucocentric. Now we've become cardiocentric. It is like as if you've moved from one tunnel vision, one tubular vision, to another tunnel vision, another tubular vision. Equally bad, equally myopic. The right way of managing diabetes is to have a comprehensive, holistic, person-centered management. And that is actually what we all do as doctors. Our chairpersons also, when you look at the person in front of you, you do not break that patient into different bits and pieces. You look at the different organ systems for your convenience. But the patient doesn't come and tell you, fix only my liver or only my kidney. The patient comes and says, give me holistic health. We understand all this, but sometimes in our subject, in our specialty, we tend to ignore the basics. Now, let's look at architecture, or let's look at buildings. The most stable architectural building or design is the pyramid. That is because the base is strong. So over the next 20 minutes, let's talk about something basic. And we'll talk about anemia. Hemoglobin, just a very tiny, tiny element, iron. Hemoglobin, a very small protein, but it actually makes a lot of impact. In endocrinology, we are very fond of saying that it is hormones which run the entire body. It is hormones which allow us to talk to each other. Pheromones, for example. So if you say that one particular person is attractive, it is his or her hormones which are speaking to you. Within the body, when supposing the hypothalamus and the thyroid have to speak to each other, or the kidney and the adrenal have to speak to each other, it is hormones that talk to each other. We are very fond of repeating that again and again. But actually, how does the body nourish itself? Through blood, through various cells, including the RBCs. So let's look at the rubro-metabolic syndrome. The term rubro-metabolic syndrome was coined because it is important. Because rubber or red or iron impacts each and every aspect of metabolic health. Let's focus today on how RBCs or hemoglobin or iron impact diabetes. To understand that, let's remind ourselves of the definitions of anemia. Anemia is defined as an HB less than 12 gram% in men and in postmenopausal women. But for younger women, we have a different definition. This is from WHO, that is less than 11. And severe anemia, we all remember the gold figure, HbA1c 7, that is our target. So 7 reminds us that the definition of severe anemia is a hemoglobin less than 7. Once we have these definitions, then we understand that anemia is quite prevalent. Irrespective of where you are in the world, anemia is common. It is a very common nutritional deficiency. Unfortunately, it is hidden. So again, speaking of history of medicine, earlier there was only one type of malnutrition, that was protein energy malnutrition. Then we understood that obesity and overweight are also malnutrition. So we had two types, protein energy deficiency and energy excess. Both are malnutrition. But then the WHO coined a new term which is called hidden hunger. Hidden hunger because it is hidden. We cannot see it from afar. Hidden hunger is defined as either vitamin deficiency or mineral deficiency. And in mineral deficiency, the commonest is iron deficiency across the world. There is a third type of hidden hunger that we sometimes see in our clinics. In India, actually, we see it very frequently. That is water deficiency and sodium deficiency. Heat exhaustion, dehydration. Even in Bahrain, the holy month of Ramadan is coming up, so there will be some people who will suffer from hidden hunger, which can be dehydration, which can be dyslipidemia. So all these are also types of malnutrition. And when you focus on hidden hunger, you try to unhide it. You try to see actually how common it is. You find that it is common, and it is even more common in persons with diabetes, both type 1 and type 2. And if the person living with diabetes ends up with chronic kidney disease, especially CKD stage 3 or 4, and even more especially CKD stage 5, then the prevalence goes up to 10-fold. So anemia is common, it is important. And if you happen to work in a less developed country, like I do, then foot ulcer, foot infections, they are another very common comorbid condition associated with anemia. This we all know that anemia will impact the quality of life. It will prevent us from exercising. It will cause easy fatigability, depression, cognitive dysfunction, and in general make us unhappy. But it is a Goldilocks kind of a thing, this hemoglobin. So we all know the story of Goldilocks. She went to the forest, she entered a house where there were bears, and some things were too big, others were too small, yet others were right in the middle. So this hemoglobin also, it is like a Goldilocks kind of a number. If hemoglobin is too much, then also we get in trouble. Polycythemia, polycythemia vera. If it is too little, then also there is disease, severe anemia. Even from a diabetes point of view, if hemoglobin is too much, iron is too much, there is a lot of iron overload. That will impact the beta cells. It can actually predispose to diabetes. That iron can get deposited in the liver, hemochromatosis, and that can cause insulin resistance, again predisposing to diabetes. So too much of hemoglobin is bad, and of course too little obviously is bad. How does anemia occur in diabetes? There are multiple causes, but let us try to simplify this picture in front of us. Post-lunch, it is very difficult to understand difficult slides like this. But look at one bucket: chronic hyperglycemia, advanced glycation end products, chronic inflammation, leading to anemia of chronic disease, anemia of inflammation. Another bucket, chronic kidney disease, along with autonomic neuropathy, leading to reduced erythropoietin secretion, leading to anemia. Early aging, premature aging of the red blood cells, which leads to early destruction, reduced lifespan, also increase in oxidative stress and increase in reactive oxygen species. Another bucket, our RBCs age very fast, the hemoglobin ages very fast, so therefore we get anemia. If this was not enough, added things may be malabsorption. In some places of the world because of helminthiasis, giardiasis. In other parts of the world because of pernicious anemia. So malabsorption can lead to malnutrition, which can lead to anemia. And if all this was not enough, with our drugs, iatrogenically, many times we cause anemia. We'll talk about that as well. So we have to be aware of it. So many causes of anemia, but the most important ones are actually related to chronic kidney disease. So anyone with chronic kidney disease, we have to be more vigilant. We have to be rubro-vigilant. We have to be vigilant for anemia. Anemia can occur with inflammation as well, chronic inflammation. And let me talk about a hormone known as hepcidin. HEP comes from hepatocyte. Cidin, because it was earlier thought to be cidal, microbicidal. which is partly true as well. Hepcidin has got antimicrobial effects on some types of bacteria, some types of fungi. So this hormone, which was discovered maybe about 24, 25 years ago, has 25 amino acids, hepcidin. It comes from various organs of the body, but especially from the liver, from the right lobe of the liver. And hepcidin acts like a guard. It acts like a gateway for iron metabolism. In beta thalassemia, there is no hepcidin. So all the iron gets absorbed through the gut and you end up with iron overload, iron toxicity. In chronic inflammation, hepcidin is very high. There is increased production of hepcidin in chronic inflammation. So what this hepcidin does is, it goes and blocks all the ports where iron is going to get absorbed. So it prevents iron from getting absorbed. And it leads to something known as functional iron deficiency. So you might do all the tests, you might see that the iron studies are normal, but still there is anemia. Why is it? Because there is functional iron deficiency. And that is because of high levels of hepcidin. And the high levels of hepcidin are because of chronic inflammation, as we see in diabetes. And these high levels of hepcidin act on the liver and also on the macrophages. They prevent iron from getting utilized. So chronic inflammation, chronic kidney disease, we are speaking about these again and again. But how do we cause diabetes, how do we cause anemia and diabetes ourselves? By overprescribing. So 10 to 30% of all patients on metformin will have vitamin B12 malabsorption, and we don't test for it. The moment we cross 3 years or so of metformin therapy, the chances of developing B12 deficiency double. So it is duration dependent. It is also dose dependent. With pioglitazone, we have edema, we had fluid retention, and that can cause a dilutional anemia. ACE inhibitors and ARBs can also predispose to anemia. This is something that we are not aware of, but be aware. Also be aware that when you use a DPP4 inhibitor and an ACE inhibitor together, ACE inhibitor and DPP4 inhibitor together, which is quite frequent in practice, we are inhibiting two enzymes. Both these enzymes destroy or they metabolize a substance known as substance P. So when you inhibit ACE and you inhibit DPP4, there is nothing left to metabolize substance P. So substance P increases. When substance P increases, you have vasodilatation and you have edema. So this is an iatrogenic cause of edema, just like you have with pioglitazone. And this fluid retention that occurs can also predispose to a dilutional anemia. So we should be aware of that as well. Another common culprit is aspirin. Overdosing our patients with aspirin, and all of us are guilty. We have done a lot in the past few decades. Now we are correcting our prescriptions one by one. So aspirin can lead to microbleeds in the GIT, and that can cause anemia as well. The good thing is that GLP-1RA and SGLT2 inhibitors are shown to improve hematocrit and improve hemoglobin also in some small studies. So iatrogenically we should be aware, but the most common culprit is metformin, and every 1 gram per day of metformin that we use increases the risk of moderate anemia by 2% per year. Moderate is 7 to 10. In type 1 diabetes, and type 1 diabetes occurs in Bahrain and the Gulf as well, there are other mechanisms of anemia: celiac disease, pernicious anemia, hypothyroidism, iron deficiency. All these are common. Pernicious anemia I would like to mention here because the person who won the Nobel Prize for discovering vitamin B12 as a treatment for pernicious anemia, this person happened to have type 1 diabetes. He was on his deathbed and he was saved by insulin. This is in the 1930s. So insulin has won 4 Nobel Prizes directly, but this 5th one also we will credit insulin because of insulin, Dr. George was saved. He remained alive, he kept on researching, and then he found out the treatment for pernicious anemia, which was vitamin B12. So we've talked of various pathophysiologies, we've talked of iatrogenic aspects of anemia, and now suddenly we are all more vigilant. Am I overdosing my patients with aspirin? Am I overdosing my patients with metformin? when I know that there is nothing to be gained by prescribing more than 1.5 gram per day? Am I missing out all those edemas that occur with pioglitazone, with ACE inhibitor plus DPP4 inhibitor, with ARB plus DPP4 inhibitor? Let me go back and check. Talking of checking, we check HbA1c regularly, but we do not check hemoglobin that regularly. So why is it that in modern medicine, we are focusing on all the complicated things now, but we are forgetting the simple things? And actually, coming even to my OPD, I think I check HbA1c more frequently than hemoglobin. So which is wrong on my part, because hemoglobin impacts the value of HbA1c. In iron deficiency anemia, in nutritional anemias, HbA1c is relatively higher than the glucose. So you may overdiagnose pre-diabetes and you may overdiagnose diabetes if you focus on HbA1c alone in a person with iron deficiency anemia. Similar ups and downs can occur with hemoglobinopathy, with hemolytic anemia, with uremia, that is chronic kidney disease, and also with pregnancy. Now, hemoglobinopathies is something important, and I would request our chairpersons to correct me, but in Saudi Arabia, beta thalassemia is common and sickle cell is very, very common. And same should be true for Bahrain. So we must be careful about using HbA1c in those patients as well. If you are confused, you stick to structured glucose monitoring. We can also do serum fructosamine to check for patients. That will tell us about glucose over the past 3 weeks. And of course, now we have very good quality continuous glucose monitoring, intermittently scanned CGMS and continuous GMS. So those are more useful for patients with sickle cell and with beta thalassemia. If glucose and HbA1c are concordant, then you treat as per policy. But if glucose and HbA1c are discordant, we have to think of a reason. The commonest reasons are that the patient is telling a lie. The SMBG values are so beautiful, but the HbA1c is high. It means patient is writing the wrong glucose values. But for that also now you have technology, you can check. If all that is kept aside, all the psychosocial aspects, then the commonest reason will be iron deficiency. So especially if you have a patient with elevated HbA1c, as compared to glucose values, you look at the hemoglobin. If hemoglobin is low, then you look at the MCV, the mean corpuscular volume. If that is also small, the corpuscles are small in volume and they are small in hemoglobin concentration. That means it is iron deficiency. For iron deficiency, usually we do serum ferritin, that is a standard test. But we forget that ferritin is also an inflammatory marker, just like CRP. It is an inflammatory marker. During COVID, all our colleagues in internal medicine, they kept on checking serum ferritin D dimer for all their patients. So if ferritin is high, it does not necessarily rule out iron deficiency. Because ferritin can be high because of chronic inflammation. It can be high because of another infection. So you may have iron deficiency and high ferritin, for example, in a person with severe COVID or with tuberculosis. We are speaking of this topic because it is important. And one of the most important things is heart dysfunction. So you must have realized that now we speak more and more about SGLT2 inhibitors, and we are also speaking about heart failure. The definition of heart failure has been made in such a way that each and every patient coming to our clinic, to Dr. Hussein's clinic or to my clinic or to our chairperson's madam's clinic, each and every person coming to a metabolic or medicine clinic automatically has heart failure stage A because person is at high risk. So that means we have to be that careful. But we will check the thyroid, we will check the testosterone, we will check glucose, and we forget to check hemoglobin. While actually, in persons with anemia, the risk of systolic heart failure is more, the risk of diastolic heart failure is also more. So this is one of the commonest predisposing factors to heart failure. When we classify heart failure, our colleagues in cardiology will tell us preserved ejection fraction and restricted ejection fraction. But they forget to tell us about high output heart failure, increased ejection fraction, which will be found in AV fistula, severe anemia, and uncontrolled Graves' disease. 3 common causes in the OPD. So the patient can go for echo. Echo will say 65% ejection fraction, 70%. Patient will come back feeling very happy. My heart is working 70%. Actually, that is high output heart failure. And it is because of anemia. Most common is anemia. Anemia is also associated with markers of severe risk like NT-proBNP, CRP, and AVP, arginine vasopressin, all different types of hormones. NT-proBNP, N-terminal proBNP, is now approved as a risk stratification tool for asymptomatic persons with type 2 diabetes. So annually it is recommended that you do NT-proBNP for all your patients, asymptomatic patients in the OPD. The cutoff is 125 picogram per ml. If the value is more than 125, it means patient is at high risk of heart failure and we should institute therapy before the patient gets admitted. The most important therapy we can institute is iron actually, because anemia has the highest risk association with cardiac dysfunction. That is followed by obesity and then followed by antihypertensive use. So anemia is a stronger correlate with heart failure as compared to even obesity. We are speaking of heart failure, but what about microvascular complications? So retinopathy, autonomic neuropathy, nephropathy, all are associated with anemia, and a multi-systemic or a multi-dimensional disease like foot ulcer is also associated with anemia. In fact, the more the anemia, the more the renal impairment, and the more the anemia, the worse the control. Pregnancy is another important aspect of life where we must focus on hemoglobin. So we talk of metabolic memory and glycemic legacy, but let me use a term called transgenerational legacy. So A, B, C, D, E, 5 things to remind the lady who is antenatal. Before pregnancy and during pregnancy, if you can fix 5 things: A for anemia, B for blood pressure, avoid preeclampsia PIH. C for circumference, circumference of the mother, that means weight gain during pregnancy. Not too much, not too little. D for diabetes, gestational diabetes, and E for endocrine. In endocrine, read TSH. So just to remember A, B, C, D, E, when the expectant mother comes to you or someone comes for preconception counseling, anemia, blood pressure, circumference or weight gain during pregnancy, D for diabetes, E for TSH, endocrine. If you can fix 5 numbers, the mother's health is improved, the fetus health is improved, and also the health of the offspring. When the offspring grows up, that offspring will not have metabolic syndrome. So that is transgenerational karma or transgenerational legacy that we speak about. But let us speak about management as well. You follow standard protocol as we do in our OPDs. If there is anemia, you look for the type of anemia. First of all, review the CBC. So the simplest way is first look at hemoglobin. Then all those numbers are there which confuse us. So then you look at PCV or MCV. You look at the mean corpuscular volume. Decide whether the corpuscles are large or small. If they are large, it is probably megaloblastic anemia. If they are small, it may be iron deficiency or anemia of chronic inflammation, chronic disease. That you can decide based upon ferritin. And you have to treat orally or with oral or intravenous iron. If hepcidin levels are very high in chronic inflammation, if hepcidin levels are very high, they also act upon the GIT and they prevent oral iron from being absorbed. This is called functional iron deficiency. And you may see that your patient is not responding to oral iron. Then intravenous iron is the treatment. And if you are able to treat the anemia properly, you will also be able to improve HbA1c finally. Glucose-related markers improve and long-term outcomes improve. We are able to prevent progression of macro as well as microvascular disease. So this was our talk for today. I look forward to questions and comments, and I would request our chairpersons to add value, the local etiologies of anemia and maybe some mistakes that we make in our practice which we can correct. Thank you, madam. Thank you, everyone.